Hi, Dr. Reeves here, back with another neurology talk. This is about multiple sclerosis treatment. I'm sitting down here in my sort of man cave full of electronics equipment and guitars and amps. It's the only quiet place in the house. So let's explore multiple sclerosis treatment. Now, when I started doing neurology, two things were different. One, I had hair. Two, when we diagnosed someone with multiple sclerosis, we kind of said, best of luck, hope it goes okay. We really didn't have any effective treatment. Then in 1993, beta-seron, which is an injected interferon chemical, came to the market. It was just blew us away. For the first time, we had something that would actually prevent a certain percentage of relapses in a reasonable chunk of people. So that was very exciting. Now, 20 some odd years later, we have 10 or 12 treatments that are very effective for multiple sclerosis. They're getting more effective by the year. I want to break the treatments up into 3 or 3.5 groups so that we kind of wrap our heads around it. I'm going to call the first group the first-line treatments. And there are 4 injected treatments. In the United States, their trade names are beta-seron, Avonex, Copaxone, and Reeves. And each of them has to be injected. You have to do it anywhere from daily to weekly. The interferons have a certain number of side effects that are relatively common, usually not so bad. People won't use the medicine, but kind of a flu-like feeling and such. And no matter what you're doing, injecting yourself is never the high point of anybody's day. So the first-line drugs, not bad though, significantly reduce the number of attacks people have over time. And then the second round, and when I say first line, second line, first group, this isn't better or worse necessarily. We finally, after years of people injecting themselves and saying, please, Dr. Reeves, don't you have a pill? We actually got some pills. So Tecfidera, Gilenya, and Aubagio are 3 oral medications you take by pill that work as well or maybe a little bit better in some cases than some of the older injected treatments. Fantastic, we have new options. I'd much rather take a pill once a day or twice a day than inject myself daily or weekly or anything like that, particularly if it seems to be about as effective or maybe even a little bit better. So yay for that. Big advance. The next round of treatments is what I'm going to call the mabs, M-A-B, and it stands for monoclonal antibodies. So whenever you hear the name of a drug, blah, 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 mab, you know that that's a monoclonal antibody. In other words, it is a produced antibody. Antibodies are those molecules that your immune system makes to go around like a special key to fit into a special lock, and it only fits in that lock. So there'll be an antibody in your blood to fight flu viruses or strep throat bacteria or something like that. Well, these are very pure, and they can be designed to sort of attack or latch onto a very specific kind of molecule on a very specific kind of cell. So this is a unprecedented laser-like ability to shut down a tiny bit of, say, the immune system. So the new revolution in MS treatment is the mabs. It started actually about a decade ago with natalizumab, also known as Tysabri in the United States, and it works really well. It prevents more attacks than anything that I've talked about. It's an infusion that you would get monthly, and things were going great guns, particularly if the first group of medicines, say an injected medicine or an oral medicine. Now this is actually, it came on before the oral medicines, but if the injected medicines weren't working, then an infusion once a month was a pretty good deal. And particularly it was more potent. But it ultimately was discovered that it unfortunately would trigger a latent infection. Some of us have something called the JC virus that's just hiding in our brains. And there's a typically less than 1 in 2 to 3,000 chance that could kind of reactivate and blossom, which could be devastating or actually kill someone. So that took a little wind out of our sails. Now we're into the new wave of the mabs. The most recently approved one in the United States is ocrelizumab. There's daclizumab, alemtuzumab. I know they sound like alphabet soup to me too. But my point behind this is that the flavor of MS treatment is rapidly changing, and it appears that the strength, if you will, is also rapidly changing. So, for example, with the most recently released antibody in the United States, ocrelizumab, it looks to have more in the range of 95-ish% suppression of disease activity for an infusion that you have to take twice a year. Some of the other mabs are really also very impressive. So now we're kind of coming to a little bit of an ethical or personal kind of quandary, if you will. Of course, none of these therapies is cheap. But we now are faced with the question of, well, what do you try first? And I'm not telling you that I have the answer, but in the 90s to early 2000s, it was, well, you pick your injected therapy, and there were 3 interferons, and there was Copaxone. So you kind of messed around with the interferons, see if you get one of those to work, or you go with Copaxone. Okay, and that was it. And then there was, well, now we got 3 pills, and so, well, maybe we should not start with injectables and start with a pill. I like to do that because I think if Mrs. Reeves developed MS, I'm pretty sure she'd rather take a pill every day than get injected, and particularly if the pill's going to work as well, if not better. So a lot of us now are starting with a pill, but if the disease seems to be kind of aggressive, put somebody on a pill, and by golly, 3 months later, either clinically they've had an attack, or on the MRI scan they've had an attack, and you kind of know, maybe this isn't shutting everything down quite the way I wanted to. Yes, the drugs, they kind of don't necessarily kick in immediately, so maybe 3 months might be a little early to declare failure, but certainly before a year, we ought to have a really clear idea whether the medicine is working or not. And the monoclonal antibodies are currently thought of as sort of, well, they probably should have failed a couple of the prior available treatments before you move to the big guns. Now, that's an interesting mindset, and I understand it because I've participated in drug development in several areas of neurology myself. And you're reluctant to come out with a new therapy and say, well, this ought to be leapfrog to the front of the line, that everybody should get this therapy, although there are times in medicine that happens. Part of our hesitancy is this JC virus problem in the brain that I mentioned about Tysabri. PML is what we call the disease when that virus pops up. So you'll hear about this PML, Tysabri triggered PML, or allowed PML to erupt in a small percentage of people. Well, we're now keenly watching for PML and all the new mabs, and of course we're going to be pretty upset if one of them seems to have a high rate of PML. The newest one, ocrelizumab, about which there's justifiably a fair amount of excitement in the United States, is actually related to rituximab, which is a monoclonal antibody that's been around for quite a while. So we have a pretty good sense. Is this going to be a real bad actor on the PML stage or not? And early on, so far it's looking really good. Eventually the day is going to come that someone who's getting one of the newer mabs, newer than Tysabri, gets PML. Well, also remember, people got PML from time to time before we invented the mabs. So, you got to be a little careful in looking at a single case and saying, aha. But nevertheless, we're keeping really close track in the United States on the cases of PML because everyone's worried about this. Long story short, very likely the rate of PML with the newer mabs is going to be much lower. It's never going to be zero, simply because people get PML other times anyway. The other thing that kind of is messing up the equation, if you will, is that people move from therapy to therapy, and as you kind of tweak and influence the immune system to treat MS, you're kind of over the years, months and years, you're already increasing the risk of PML. And so somebody might take Reeves for 3 or 4 years, and then they go on Tecfidera, and maybe they had a course of Tysabri for a year and a half, and now they're treated with alemtuzumab or what the heckimab or some other mab, and they get PML. Well, your natural thought is, well, it must be that thing that they're on now, but in fact it's probably a cumulative effect of all the immunomodulatory therapy that they've had for their MS. Boy, that was a little complicated. So, first line injected treatments, second line, or new and improved oral treatments, new and even more improved antibodies. It's an exciting time for MS. That's for prevention of attacks. What do you do when you have an attack? Well, you call your neurologist. And typically, we go through a protocol of infusing through the vein steroid medications. And they are not Arnold Schwarzenegger steroids, they're cortisone steroids. And I've had them by pill myself before. I didn't really care for how I felt. They kind of jazz your system a little bit. And we often will give 3 to 5 days of an infusion one time a day, followed by pills that you take in a declining dose over time as you wean off. And that's the whole goal, is to try to settle down the immune inflammation that's gone on faster and promote more rapid recovery. When you're on that kind of treatment, we have to make sure you have anti-acid medicine like omeprazole so you don't get an ulcer. If you have diabetes or even borderline diabetes, we've got to keep a close eye on the sugar. And it tends to make people sometimes a little irritable or a little wound up, and they sometimes can't sleep, and they sometimes are raiding the refrigerator at 4 o'clock in the morning because they have a ravenous appetite. All of this goes away when the medicine leaves the system. You may have heard about cortisone-related complications, problems. People have to take prednisone daily for months and years. The thin skin, the weight gain, the thinner bones, all of that kind of stuff. We worry about that, but that's really when you're on the stuff long term. This is typically a short blast, if you will, to try to knock down the inflammation, get things to chill out, and get on the road to recovery. So I hope this has been helpful. Primarily what I want you to take away is you have a general understanding of the kinds of approaches to treatment in terms of the injections and the pills and the antibody infusions, the use of steroids, and I want you to be able to talk to your neurologist very plainly and clearly to get the care that you need.